My guest today is Dr. Sara Norris. Sara is a doctor of naturopathic medicine and one of the physicians I get to work alongside at Wagner Integrative Health. She graduated from the National University of Natural Medicine in Portland in 2010, and before landing back here in Wisconsin, she practiced in Oregon, California, and Vermont, states where naturopathic medicine has been licensed and fully scoped for decades. What that means in practical terms is that Sara has spent most of her career doing the full weight of primary care, well child visits, annual exams, prescribing medications, hospital admitting privileges. She's also trained medical students and been the attending to naturopathic residents. She's not a physician who chose the alternative lane. She's a physician who's worked inside the system and outside of it. And that's exactly why her perspective is the one I wanted on this show. These days, Sara has stepped away from primary care and turned her full attention to integrative and functional medicine. At our clinic, she specializes in women's health, things like endometriosis, PCOS, fertility, menopause, the hormonal terrain most women are navigating without a map. She also works in pediatrics, skin health, and digestive health. Sara is a Wisconsin native. She came home to be closer to family, which happened to land her here right as Wisconsin finally passed licensure for naturopathic doctors in 2022. She's now the legislative chair of the Wisconsin Naturopathic Doctors Association, working to modernize the scope of practice in this state. Outside of the clinic, she's a mother of two, a wife, and by my count, the keeper of 2 dogs, 5 fish, and a rescue cat named Itchy Kitty. When she's not at work, she's outside, gardening, hiking, kayaking, snowshoeing in the Wisconsin winter, which tells you most of what you need to know about her. Today, we're talking about PCOS and infertility, 2 diagnoses that get handed to women far too quickly and far too often without the full conversation. Sara, welcome to the show. Hi, everyone, and welcome to the Wealthy. As I said before, we have Dr. Sara Norris here, who is a wonderful naturopathic doctor in the practice, and we have been so blessed to have her here in Wisconsin. And today we're going to talk about, I'm going to call it PCOS, but let's just start with that right away. What do we call it now?
Right, now we're calling it PMOS, and the intention there is making sure that we underscore that this doesn't necessarily mean that you have to have cysts on your ovaries to be labeled with this PMOS, previously PCOS. So polyendocrine metabolic ovarian syndrome. I'm still learning the new.
I'm not going to say that.
PMOS, right? To say it all out, the whole diagnostics, but it is something that does not change the criteria. If you were previously labeled with PCOS, now the new name PMOS applies to you, and I've seen it really bear out. I've already seen people who are engaging with their primaries and gynecologists, and they're understanding that you don't need those cysts on your ovaries for diagnosis. Again, we'll talk today about that diagnostics and what you need in order to make that diagnosis on a patient.
And I think people will still hear the word PCOS a lot.
Correct.
I mean, I think I'll probably still use that for a while because I'm kind of an old dog. Hard to get used to new tricks, but so PCOS or PMOS, same thing.
Synonyms.
And what exactly is it?
Yeah. So PMOS will, let's talk about what you need for a diagnosis. I know our plan was to talk about it in a little as we flow through this conversation, but it requires two of 3 things in order to make that diagnosis. So we're looking for high androgens. We're looking for irregular cycles or a LH to FSH ratio where LH is double. That's no longer a diagnostic criteria, but you can just diagnose based on irregular cycles. So, and then the third would be cysts on the ovaries that are polycystic or what look like a string of pearls. So small cysts, not single large cysts that have potential for rupture. Or an elevation in AMH. So that sounds like a list of 5. That's actually a criteria of 3 that's broken down into those 3. What it looks like in somebody, if this is you, is hirsutism, so hair where you don't want it, chin, upper lip, low belly button, low back, and irregular cycles. So we're not talking about sometimes I get 28 days, sometimes I get 32 days, but really more like my periods are happening every 40 days or longer. You can make that diagnosis now just based on those 2 symptoms alone. I think that it is better to be making that diagnosis based on labs.
And you mentioned high androgens, just for the audience, that's high testosterone.
Right.
Does that include DHT as well?
That includes DHEA and androstenedione.
Okay.
So it's important to be running all three. It's unusual to see androstenedione elevated without a DHEA, typically sulfate elevated as well, or a testosterone elevated, but it is the three.
And I'm seeing so many people online making everyone think that they have this. What do you think about that?
Yeah, I mean, it is common.
More common now than it ever has been.
Right. It is like 8 to 13% of women in their reproductive years.
8 to 13%.
8 to 13.
That's a lot.
Right. Yeah. So it is common out there. Not having regular cycles does not mean you have PMOS, right? And that's why it's important to do these labs in order to talk about what are the other potentials and then how do you treat it.
Because I think, like, just having been in medicine for a while, the typical PCOS patient, you could see them and you knew they had it. Because they had, there was the body weight, there was the hirsutism or the hair, excessive hair growth, the irregular cycles. You could figure it out pretty quickly. But now we're seeing a lot of people that don't fit the mold when you look at them. But they definitely have it once you dig into their details.
Right.
You're seeing that as well?
Right. And I think those details matter if you are a person who doesn't want birth control as your solution currently. And there's nothing wrong with birth control, right? We think of birth control as a Band-Aid for helping hormonal concerns, and it's not a bad Band-Aid just because we use that terminology. And especially if you're having sex with a male body person and you don't want to be pregnant, birth control is a great solution for that moment.
So what would someone's first steps be if they've been like looking online and kind of considering that they have PMOS? What would you say their first steps would be?
Yeah.
Obviously coming in for an appointment.
Right, coming in for an appointment. If you're looking to understand your hormonal picture and a grander scheme of things, I think before you jump onto birth control is really nice to try to advocate for, can I get some baseline labs before I go on to birth control? Because it does take 3 to 6 months before you see hormones regulate coming off of birth control. So, maybe this is a nice time, no birth control, to get that baseline so that you come in and you have a better idea of, all right, in 5 years or 10 years or wherever you may land, I don't want to be on birth control anymore. What am I going to be up against? So this is where my baseline was, what's changed in my life, because it can definitely change based on what you're doing lifestyle-wise.
And also I would think if you're someone who's younger and you don't want to have kids, but maybe in 5-10 years you do want to have kids, it's probably a good choice to look at the root cause and figure out your lab data, what your hormones look like,
right? And
even try to treat it naturally. Right? Like, so what would you say the difference is for someone if they go to their gynecologist for this diagnosis versus if they came to you?
Yeah.
How would the approach differ?
I think it really, what's going to be different in what I'm going to call the integrative medicine landscape, which is what we all do here, right? I think it's really the marriage of the two worlds of what I'm going to call conventional medicine, what you're going to be offered from your gynecologist, who may also be trained in integrative medicine, and what you'd be offered by somebody who's trained in things additional to the pharmaceuticals, is it depends on what you want. If you're a person who thinks, I need birth control anyways, I'm not interested in conceiving ever or anytime soon, and you're, I would say in your teens or 20s, I think birth control is a fine solution at that moment. Maybe you don't need to be coming to somebody in the integrative medicine realm, especially if you do well with birth control. Not everybody has to go outside of what their primary care doc can provide or what their gynecologist can provide. But if you're somebody who's already tried birth control and didn't do well with birth control or doesn't need or want to be on birth control, then we should really be talking about what labs you should be asking for, especially if you have a provider who's not well versed in this to begin with. Because
there are a lot of natural options for patients, right? A lot.
Yeah, absolutely.
And there's lifestyle changes.
Yeah, absolutely.
Like high protein diet and strength training and inositol and I could go on and on. Right. She helps me with these cases a lot. Yeah. And a lot of these times the natural therapies work pretty well. Wouldn't you say?
Right. They work. I think the biggest downside of the natural therapies is how much you're taking sometimes, right? It's, as an overall arcing theme, we would say hey, it's out of pocket. You're probably taking more than a pill a day. So there's the expense and the extra stuff to take, but the positives is usually less side effects. And that's not to say natural things don't come with side effects and that they don't interfere with pharmaceuticals. So it's really nice to have somebody well versed in these interactions, help you navigate that world of, let's be honest, social media and friends who are all well intended, but their PMOS may be different than your PMOS. You may not have PMOS, and that may be why you're not getting the benefits from what you're taking. And also, let's not forget that the FDA doesn't regulate supplements, and that means that anybody can say anything on a bottle. You can see great Amazon reviews for something. Those could have been all paid for, or those could be honest
and
reviews.
Heavily influenced by an influencer.
Right. And may not actually have what it says it has in the bottle. So you could be doing all the right things with the good information you've sleuthed out on your own and not have a benefit because it's not what it says it's in the bottle.
Yeah, I had an experience this week with 2 different people using stuff that they found online that an influencer was selling or endorsing. And I was like, no, that is not the right thing. Some people are really, really desperate. They're going online, they're trying all these different things, but that's not always the right way to go either.
Right.
How often have you seen lifestyle make a big difference for people with PMOS?
Yeah, I think lifestyle is plays a huge role in PMOS because one thing that we didn't highlight yet was about this insulin sensitivity. Right. So we see with PMOS, we see higher risk of diabetes, we see higher risk of preeclampsia or high blood pressure during pregnancy, we see higher cardiovascular risk later on in life, even continuing into menopause, so no more periods. And so lifestyle plays a big role for all of us, right? The baseline recommendation for someone with PMOS or all of you out there is 150 minutes of cardio a week. On the dietary side of things, it is really, research always kind of keeps coming back to Mediterranean diet, right? Like you look at across a variety of diagnoses and complaints, Mediterranean diet continues to win overall. And what is that? That's reducing your saturated fats, that's eating at least 5 cups of fruits and vegetables a day. It's an anti-inflammatory diet. Do
you think there's a piece of the high protein diet that also fits into the picture? Because I keep seeing that really people are saying people with this should eat a higher protein diet, or do you just think that's something everyone should do?
Yeah, I think protein's important because of that insulin sensitivity, right? So the idea there is stabilize blood sugar. And should everybody have a higher protein diet? Yeah, I think so. Quality proteins and making sure that we're getting lean more often. Your turkeys and your chicken and your fish versus an over-reliance on your dairy and beef products in particular, but not that those are bad.
Right. How much do you see stress play a role in this diagnosis, and how much do you think it's genetic versus environmental versus stress?
Right.
If that's a hard question to answer, I can break it down more. But
right, yeah. I mean, there are first of all 4 phenotypes related to PMOS. So, and they're basically a combination of do you have those high androgens, so testosterone, DHEA, androstenedione? Do you have cysts on your ovaries? Do you have irregular cycles? So mix and match those 3, and that's where you get those 4 phenotypes. The high cortisol doesn't have its own phenotype, but definitely contributes to any of those 4. The phenotypes help you determine what are the appropriate treatments, whether this is medication-wise, metformin or spironolactone or birth control or a combination of all 3. But once you get into the natural realm, that's where I think it really makes a big difference, working on the lifestyle components.
So the lifestyle is not necessarily going to cause this syndrome, but it's going to maybe exacerbate it or make it harder to manage, would you say?
Yeah, I mean...
As with any disease?
Right, yeah. And
cortisol is going to make any of them worse?
Cortisol is going to make
high cortisol.
High cortisol is going to make any of them worse. Yeah, absolutely. I mean, it is... I wish it was as easy as like breaking it down by percentage, right? Like what we know on the environmental side that you were talking about is that women with PMOS have a higher concentration of phthalates, parabens, forever chemicals, heavy metals, lead, mercury, cadmium, arsenic, like there are in the are higher contaminant levels. Is that about detoxification, or is that about exposure? Is that underlying genetics around how we detox those environmental components? Does that go back into genetics like COMT and therefore higher adrenaline
Right.
and detoxification? So is there underlying mechanism that actually maybe ties stress and the environment together?
Right.
Potentially with your genetics.
That was very heady.
Yeah.
That was,
That may
I'm
have been
gonna,
too
I want to
much.
repeat this. Yeah. So you're talking about environmental toxins are found to be higher, and that's a whole basket of stuff that she mentioned, the metals and the parabens, etc. Found to be higher in the bodies of women with PMOS. And is the problem that they're exposed to more of those things, or is the problem that they genetically do not detoxify those things as well? Because we do a lot of genetic testing here, and it's fascinating because people have certain genes that affect their ability to excrete things out of their body or detox things out of their body, and we can see it in the patients. It's crystal clear. So the question is, do they have those genes, and that's why they're not detoxing as well, or are they just getting exposed to more things?
Right.
So I mean, I think in general, it's still always good to follow a lifestyle where you try to avoid these things, right? You try to use the clean skincare products. You try to avoid the plastics. You try to buy cleaning things for your home. But also there's some things that we just can't get away from.
Right. Yeah. And so, it's one of those things where this is great for everybody, of course, but making those changes doesn't change your hormones that next month that you make those changes. These are underlying things that can help all of our health, and using nice resources like environmental working groups, Skin Deep website, or their app, or Yucca, YUKA, as an app to scan all your products is a good starting place. And then
Does Yucca do products as well, not just food?
Yucca does products as well.
Okay, I didn't know
Yeah,
that.
so like sunscreen, etc. And then start with the things you wear all the time, right? Like I probably put 12 different things on my head every morning.
I know. Okay, I'm not alone.
Yeah. Right. So if I'm putting it on, particularly if I'm putting it on my face or on my scalp, but arms count too, it should be clean enough that I could eat it because I'm basically eating it. Right. I am
direct absorption
it's
in your
direct
bloodstream.
absorption into your bloodstream. And there is, there's this term called greenwashing, which is like putting a term like natural on a product, and you can increase the cost associated with that. And that product very well might be more natural, but just because the marketing makes it look good doesn't necessarily mean it's a cleaner product. And you can find cheaper products actually better by just taking some time to look at that.
And that's why those apps are great. So she said Skin Deep, which you can find very easily. It's an app that you scan products with, and it gives them a rating, or the Yucca, YUKA app. Both my patients use them all the time, and I think they're really helpful. But one thing I do want to add is I try to be careful with patients not to overwhelm them because maybe they're getting a new diagnosis. I don't know how much stress they have in their life. I don't know their financial means. And then here I'm telling them to avoid all these products and plastics, and it can be overwhelming. So one thing I think people have to realize is that these changes don't happen overnight. They'd happen over years. I'm still making changes with my lifestyle and what I expose myself to. And then sometimes I say, I just don't even care. I'm just going to do it anyway. So none of these things are absolute that you have to do, but there's so many things you can do to try to improve your symptoms, your syndrome, make your hormones work better, increase your chances of fertility, decrease your chances of diabetes. So there are things you can do, but it can be really, really overwhelming, and it does not need to be done overnight.
Yeah.
And I think that was one of the questions I actually wanted to ask in the beginning or talk to you about is, I think a lot of people think of PMOS or PCOS as just a reproductive syndrome, but as you touched on before, it affects so much more.
Right. Yeah, we think of it, you would think about it like, oh, okay, this affects me from menarche, my very first period, until my last period, and once I hit menopause, I'm good. Take the ovaries, I don't want this anymore. But ovaries are still producing small amounts of hormones in menopause, but really what happens is we see that insulin sensitivity, insulin resistance component associated with PMOS affecting heart health and, and then the diabetes component too.
Even into menopause.
Even into menopause.
Okay.
And that's not to say be worried about it. I think one of the big messages I wanted to drive home in the talk today was about fertility and PMOS, and this.
Let's talk about that.
Yeah. Because what I hear from a lot of women is that fear of like, I'm going to have trouble conceiving when I want to conceive. And the reality is what we're looking for is to get you ovulating. If you're ovulating, I'm not worried about your fertility. If you're having regular cycles without birth control, that is a really good sign to say you're ovulating. And there are tests for that in order to determine if you are ovulating, to give you that kind of reassurance.
And that's why if you're someone who you do know you want to have children someday, maybe birth control is great for you to control your symptoms, but before you do that, investigate and figure out what works for you to get you to ovulate.
Yeah.
Maybe go on birth control for 5 years.
Yeah.
And then give yourself that year to actually conceive.
Right.
And get yourself ovulating again, do you have pretty good success? I feel like you do.
Yeah, I think
really
do.
good.
Yeah, absolutely. So it's something I would say if you are 30 or older and you're interested in conceiving, having your own genetic babies in the future, really think about taking a 6-month break on your birth control if you're on it, or getting that evaluation around your fertility, because we do see declines in fertility in all females around age 32, 33. We know that women are getting pregnant older, but that's not because our fertility is improving as a society. It's actually getting worse. It's just we're getting better at IVF. So if you're someone who is interested in conceiving, and 30 is kind of my age, but 32, 33 is like the cutoff where you really want to start thinking, let me get this evaluation and determine, should I be doing something like freezing my eggs so I can preserve that fertility until the time I'm ready.
And you see a lot of women doing that?
Yeah, absolutely. I mean, at least know where you stand. You don't have to freeze your eggs. You don't have to do this 6-month pause and do anything about it. But at least it empowers you and you don't have that regret.
And that's the one thing I would say, and this is not bashing our gynecologists at all, because our gynecologists are wonderful.
Yeah.
But like in traditional training, we're not taught these natural therapies and lifestyle changes you can make to support PMOS and to improve your fertility. So if you're someone who goes on birth control at 18 and then goes off at 30, and then you want to try to start conceiving, but you've never done the diagnostic workup and you've never done the detective work and you haven't tried the natural therapies to get yourself to ovulate, it could take a lot longer.
Right. And I think I'll echo what you just said and just say it's okay to use the medications and what you've been given from your primary or your gynecologist. Those are great tools. They don't work for everybody, and know that there are other tools that do work just as well as the medications. Sometimes people respond better to medications. Sometimes people have side effects to the medications where they're required or need to explore something that isn't the pharmaceuticals, or they just want to. So every person gets to make these choices for themselves.
And a lot of people do both,
right?
Don't you think?
Yeah,
like a lot of people
absolutely.
are using natural therapies, but then they're also using Western medication,
Right.
Western meds, which is totally fine.
Mm-hmm.
The other thing I do want to touch on too is GLPs. So in my practice, I have found that people with PMOS actually do really, really well on GLP-1 medications. It used to be metformin for everyone, and I'm really seeing that kind of going by the wayside. Are you seeing that as well in your patient population?
I am. Yeah, I think there's more interest in GLP-1s overall. Semaglutide seems to be having some really great research that's coming out about it. I was reading about another GLP-1 that I haven't used related to PMOS that's even performing better than semaglutide. Tirzepatide, Zepbound, I've seen some really nice success on the inflammation side of things. We're still a little weary about tirzepatide while actively trying to conceive versus semaglutide. So semaglutide up until conception seems to be an A-OK. Some research said maybe take a break at 2 months. What I'm seeing more from reproductive endocrinologists and gynecologists, and some meta-analysis is showing, there's, we're doing studies looking at safety of the pregnancy and baby's health post semaglutide use or Ozempic, and there isn't any concern thus far. So superior to metformin, and in terms of helping potentially with, we always measure these things via IVF so that we can really manipulate those numbers in terms of pregnancy outcomes. So significantly better IVF outcomes.
And you mentioned inflammation with tirzepatide. So do you see that a lot of patients with PMOS actually like can feel that extra inflammation that they're carrying for sure, right?
Yeah, absolutely. Yeah, that's really something that's fascinating in the last probably 2 years, right, is seeing Zepbound or tirzepatide and that inflammation coming down in a variety of conditions. And so I have women who just do feel better and do better on the tirzepatide or Zepbound, and then we take a break once we know that they're going to start trying to conceive.
What kind of things do you recommend for symptom management? So like hirsutism, you know, you have a lot of excessive hair. What kind of things do you tell patients to do?
Yeah, so once that hair is thicker and darker, there's nothing that you can do to reverse the thicker and darker hair besides laser, shave, pluck, wax. It will never go back to a hair that was lighter or thinner. But once you do reverse and reduce those androgens, you are having less rapid growth. So the mainstays would be spironolactone or metformin, more specifically spironolactone. These would be our pharmaceutical friends, and some birth controls as well. On the natural side of things, I definitely find spearmint tea, not peppermint, spearmint, 2 or 3 cups a day. Inositol, similar to metformin, saw palmetto, nettle root, pygeum, probably the first 2 more than the third, as herbal alternatives to our spironolactone.
Okay, and you're seeing some good success with those things. I think you are.
Yeah, absolutely.
And then obviously natural things for the insulin resistance, you can think of things like berberine.
Yep, the inositols again would be kind of similar to the metformin. Really important to do a 40-to-1 ratio of myoinositol to d-chiroinositol, and also brand really matters. Here too.
There's so many different. Like when I look for my perfect thing for my patients, I'm like, oh, there are so many options, and like 90% of them aren't the right ratio.
Right.
So you have to get the right brand.
Right, and same is true for berberine, right? Like you want a company that's third-party testing, and milligram dose matters. So the right substance at the right dose that's actually tested to show it's in that bottle.
And then we talked about like perimenopause and menopause. So in my experience, they do symptomatically get better with menopause because they're not dealing with those fluctuations in their periods and the different ranges of their hormone levels, but they do still carry those same risks that the PMOS gives them.
Correct.
While they're still menstruating.
Yeah, correct. So somebody with a PMOS history, maybe we're just looking a little more thoroughly into some of those labs. So rather than taking a hemoglobin A1C, which is a 3-month average on your blood sugar, as the gold standard, which it is, maybe you're running a fasting insulin on that person and glucose, and you're determining the HOMA insulin resistant number.
And you're looking at their body composition, how much muscle do they have, how much body fat, how much belly fat. But I have found, I feel like my PMOS patients do have more muscle.
Yeah.
Which is like a nice little benefit.
Right, yeah. So
they tend to have really good muscle mass.
Yeah, you do see the androgen levels start dropping in the 30s. So for some women, their androgens will actually drop under 50 and into that female normal range. But I do find that women feel better, right?
Right.
It's like that.
So testosterone can feel good too.
Testosterone can be really nice.
Right.
It can be nice to finally not worry so much about getting the something that's delaying your periods and menopause, and just enjoy the benefits of the testosterone.
Right. And then is there anything else you had in your mind that you wanted to share with people who are interested in this and wondering if they have it? Anything else you could think of to share, or like when or if they should come in to see you?
Yeah, I think we all can benefit from, we talked about cortisol lowering, right? So we can all benefit from lowering our cortisol levels, whether it's very clearly directed and linked to the symptoms that we're having or not. So anything lifestyle wise, like the basics, is going to benefit anyone listening to this.
Right, the boring
talk,
stuff,
right?
like sleeping, eating, exercising, controlling your stress.
Right.
Right?
Right. Yeah. It's this balance beam, right? How many things are on the stress side of things? How many things are on the like keeping me in balance? And so maybe this isn't something that you have to do. Maybe it's something you have to take away, or maybe it's more fun over here.
Right.
And so it doesn't have to be all so heavy. It can be about like more time with friends, more time with people that build you up, and getting out into nature and doing some nature walks.
Yeah, and also just recognizing if you're someone that stress bothers you more than others. There's people that can be exposed to the same stressor, but based on their genetics or based on their prior experiences in life, their body reacts stronger to things. Because that was me when I was in my 20s and early 30s. Totally different person. Like I wish I had an Aura ring back then. I really do, because I just reacted to things a lot more, and I had to do some work on that, and I did the work on it, and now it's really nice.
Yeah.
And I continue to do work on it. Do things like nature exposure, cold plunging, sauning, just daily practices that kind of chill your nervous system out, that makes your body feel safe.
Yeah.
And lets it do what it's supposed to do.
Yeah.
Yeah.
Yeah. So I think the final take home is what I said before would be, if you're a woman who's 30 or older and you have not conceived the babies that you want and you would like genetically your babies and you're on birth control, take a 6-month break, reach out to somebody with the knowledge that you need and get an assessment and see, it gives you an opportunity, one, to do that background work before it's time to go and you're ready to conceive, or two, to have the knowledge and power to understand, all right, when I am ready, I need to take this break again, and here's my team.
Right. And I was going to say, I want to add one more add-on to that, is that if you have been asking your doctor about this and you feel dismissed, because that can happen too.
Yeah.
Some people, some doctors aren't as educated on it, and a lot of doctors don't know the natural therapies for it. That's when you should seek care, maybe outside of the traditional healthcare system, with an integrative, a functional, naturopathic doctor, someone who has a little bit more of a toolbox to work with you on, so that you can get to the goals you have and feel your best self.
Right.
So
yeah. I think that's great.
Awesome. Well, that was wonderful. Thank you. This is our third round at trying this, because I was having some technical issues. So she's been very patient, so I really appreciate her being here. And I always appreciate you guys listening, and hope you enjoy the show.